Clarity goes with that? Okay, I am Dr. Murali Chand from India. Good evening, everyone. So now I will tell about how to identify the anterogenital artery and pretty sure that it is anterogenital artery. Now I am entering into this room. See, always knock the door before entering into room, anybody's room. So in the similarly, you take the straight leg sleeve and just push that like this. Push the anterwall of the bulla, that is knocking. Anterwall of the bulla, knocking, and then push it inside and open it. So then you will get an opening space in the anterwall of the bulla. Then keep a 70-degree stroke upwards and see, identify the anterogenital. So always knock the door before entering into a room. So our analogy is take a straight leg sleeve and knock it like this in the anterwall of the bulla and open it. Now we are entering into room. Come. This is just now we have removed the anterwall of the bulla. Next, immediately you see in the roof. You see in the roof. In this roof there is fan. But actually if there is tube light here, then I am giving analogy of that tube light to anterogenital artery. Suppose if there is tube light here, tightly adhered to that roof, that is anterogenital artery. That is the most common situation. Sometimes we may have hanging anterogenital artery also. That means hanging tube light. So that is, in such a situation you will have supraorbital cell. That is, you have to be very careful in that situation. So tube light tightly adhered to the tube or in a hanging tube light. So suppose if there is tube light here, that is anterogenital artery. And this space between this and anterwall, between this anterwall and this tube light, nanne focus check. Focus check. And this space between the anterwall of the bulla and this tube light, this space always present. This space, it focus. Suppose if there is tube light here, always one cell present between the anterwall of the bulla and the tube light. This upper part is upper part of the anterwall of the bulla. Even if you remove the bulla anterwall, this superior wall attachment to the skull is still present. So always one cell present between upper attachment of the anterwall of the bulla and the tublet here. So always one cell present. Similarly, now I am moving to next room. This is again knock the door before entering into another room. So this door is vertical part of the basal lamella. So here also take a blade and just do like this and then open and remove this with debrider or traditional 45 blade sleeve. But whenever you entering into another chamber, another cell zone or another room, always knock the door. Similarly, with straight blade sleeve, you do like this and then open. So now, this is vertical part of the basal lamella, and that door is anterwall of the bulla. And the tube light here, actually the fan is here, but suppose if there is tube light here, and the space between this tube light and this vertical part of the basal lamella, some space present. So you can identify this anterogenital artery just anterior to the anterwall of the, just anterior to the vertical part of the basal lamella, or posterior to the front door. Front door means what? Anterwall of the bulla. So in either way you can identify this anterethmoid artery, that is tube light in the roof, or it may be hanging tube light. Hanging tube light is hanging anterethmoid artery situation. You have to be very careful in such a situation. How the direction of the anterethmoid artery? It is like aeroplane beak, like this, anteromedial direction, aeroplane beak. So both anterethmoid artery, if you see from skull base view, from superiorly or from endoscopically also, they are like this in anteromedial direction. So our front door is anterior wall of the bulla, and this door is vertical part of the basal lamella. Suppose in intact bulla technique, you can preserve this anterior wall, front door, anterior wall of the bulla, and you can reach the frontal recess. Pass better. Pass better. In intact bulla technique, we don't remove this anterior wall of the bulla, and we work and we work here. So that is intact bulla technique. This is frontal recess. Suppose if you remove the bulla, anterior wall of the bulla, suppose if you remove the anterior wall of the bulla, it is not. Suppose if you remove the anterior wall of the bulla, still this part, this from the this bone from here, from anterior wall of the bulla to roof, the upper attachment of the anterior wall of the bulla still present. So this is very important landmark. Even if you remove the anterior wall of the bulla, this upper attachment of the anterior wall of the bulla, if you work posteriorly, you may injure the anterethmoid artery. If you work anteriorly, you don't injure the anterethmoid artery, you will reach the frontal recess. So intact bulla technique is very safe. If you work here, you can directly reach the frontal recess. In non-intact bulla technique also, when you remove the anterior wall of the bulla also, still this upper attachment of the anterior wall of the bulla still present. So this door is there. Up to here, this is the anterior wall of the bulla. You are removing. Till this brick from here to roof, this part still present. If you keep a 70-degree scope, you can still identify this small bone. So this becomes an important landmark to prevent injury of the anterethmoid artery, that is the tube light which is present in the roof. Actually here fan is there. Actually if there is a tube light, that becomes the anterethmoid artery. So I am repeating again, this upper attachment of the anterior wall of the bulla is very important landmark. If you work in front of this, it is a frontal recess. If you work behind this, and you have to be very careful whether you are injuring the anterethmoid artery or not. Okay, thank you.